Right. Good afternoon and good evening, everyone, and welcome to our webinar. We're excited to have you join us here today for this session, Bone MRI, the next step in adolescent diagnostic care. My name is Dionysios Yogas, Product Manager of MRIguidance, and I will be your host for this session. We're joined today by a fantastic lineup of experts who bring unique perspective of the use of bone MRI. First, we have the founder and the Chief Scientific Officer of MRIguidance, Peter Seevinck. Peter, hello.
Hi, good to see you. Thank you.
Then we have Dr. Sarah Bixby, pediatric radiologist from Boston's Children's Hospital. Hi, Sarah.
Hi, hello, nice to see you all.
And finally, we have Dr. Ken Illingworth, Director of Pediatric Orthopedic Trauma from Cedars Sinai in Los Angeles. Hi, Ken.
Hello.
So before we dive in, just a quick overview of what you can expect over the next hour. First, we will hear from Peter Seevinck, who will introduce you to the bone MRI technology. Then Dr. Sarah Bixby will take us through her experience of integrating bone MRI in the radiology workflow. After, Dr. Ken Illingworth will share his experience of using bone MRI to detect and monitor certain pathologies. And finally, after the presentation, we'll open up for a Q&A session. A few quick housekeeping notes. Feel free to submit your questions at any time using the chat. We will collect them and address them as many as we can at the end. And today's session is being recorded, and we will share the replay with you afterwards. Now, with that, let's get started. Without further ado, I'm pleased to hand it over to Peter Seevinck for a brief introduction into the bone MRI technology. Peter.
Great. Thank you very much for the introduction, Dionysius. I'm looking forward to presenting a bit about the background of bone MRI. So what is bone MRI? Bone MRI is an AI-enabled software, machine learning technology that provides us radiation-free CT-like images from MRI scans. Those CT-like images are three-dimensional, they are sub-millimeter accurate, and they provide quantitative values, which means they actually provide Hounsfield units similar to CT scans. These images can be made for both adults and in the adolescent population in the spine and the pelvic region. So what is actually the problem here? As you all know, in patients eligible for spine surgery, often MRI scans are being made. And these MRI scans are superior for visualizing the soft tissue. But often it's also very valuable to have more information of osseous structures, of the bony anatomy. And in that case, at this moment, you would have to make another radiological examination, which uses ionizing radiation like a CT scan. So with bone MRI, we provide a solution where all the soft tissue information, all the nerve tissue, but also muscles, the vasculature, can visualize together with the bony information from the bone MRI scan. And in that way, you have a more patient-friendly, seamless approach, one-stop shop, and you don't need to use ionizing radiation and multiple examinations. So this solution is currently certified for the total spine and the pelvic area, including the hips, both for adults and adolescents 12 years and up. So how does this work in your institute? So bone MRI comes with a specific scan protocol. This is a 4-minute protocol that should be installed on your scanner. It can be any scanner, Philips, Siemens, GE, 1.5 Tesla, 3 Tesla. And although it's a specific sequence, it is generic, so you can all use that. And installation just takes, it's very easy, can be done by your technician with some help of us. Once the sequence is installed, the MRI scans are being made and normal T1 weighted scans are sent to your PACS system. The gateway, which is a part of software that we developed, which is HIPAA compliant and information security approved, it needs to be installed in your hospital, and that recognizes the bone MRI source images. Then the gateway de-identifies all the data and it only sends imaging data to the cloud where the bone MRI reconstruction is being made, sent back to the gateway, re-identified, and a bone MRI reconstruction is shown next to all the other images, your T1, your T2, your FLAIR image, what have you. Then the specialist, the radiologist, or the surgeon can use the data, look at it in the workstation, or use it in any other way normally a CT scan would have been used. The whole workflow I described takes about 10 to 15 minutes, and it's all fully automated and automatic. So once the bone MRI reconstruction is made, you as a radiologist can make a diagnosis, but many other things that are often done in your practice can also be done. You can reformat things, you can make 3D renderings, but you can also assess ionizing or the density of your bone from the Hounsfield units that are presented. For a surgeon, the bone MRI really acts as an enabling technology. From treatment planning to determining your trajectories or your implant sizes, up to 3D printing or navigated surgery, all these different aspects normally reside to the high accuracy and the quantitative aspect of a CT scan, and now they all can be done with a bone MRI reconstruction. So all in all, that means that with bone MRI, you can have a more patient-specific, patient-centered approach without using any ionizing radiation integrated in your own workflow. It means that you have both soft tissue information as well as the bone information all at once from a single examination, providing you better diagnostic information. And in the end, if you use this in your operating theater, it leads to efficiency gains because you don't need bulky imaging machines, intraoperative imaging. You have all at once before your surgery, but also for intraoperative navigation. That wraps up my presentation, and I'm very happy to hand over now to Dr. Sarah Bixby, and I will stop sharing my screen. Sarah, if you can share your screen, the floor is yours.
All right. So perfect. Thanks so much. Again, my name is Sarah Bixby, and I'm a pediatric radiologist, and my focus is on musculoskeletal pediatric radiology. And that's kind of how I'm going to approach this talk. By way of background, I actually started working with Peter and MRIguidance team in 2021. And that's just because we're a referral center for patients with complex hip diseases. And these patients tend to undergo multiple imaging studies in our hospital, including MRI and CT, to work up the hip deformities before the surgeons contemplate a surgical procedure. And we thought this would be an ideal population to use bone MRI because we could essentially eliminate the CT scan. So we did exactly as Peter described, which was we downloaded or we installed a source sequence that could be reconstructed into synthetic CT. And as the patients underwent their hip MRI, which included pelvic imaging, we performed a synthetic CT and evaluated this side by side with their conventional CT images. And we actually found that we preferred the synthetic CT. And in many ways, this is because our patients are pediatric patients. We rely on low dose CT. And so although it saves radiation exposure, you do have a lot of noise. And so we found that sometimes when we compared our synthetic CT images to the conventional CT images, we actually preferred the synthetic CT. And so we wrote up those results and also worked a little bit more with bone MRI, looking at patients with rare musculoskeletal diseases. And we're just really, really pleased with how well this could characterize bone lesions in children even. So that's how we got to know about bone MRI. And so we were well poised to start using it once it became FDA approved. Obviously, we had to get through the legal and regulatory and IT security reviews. But once that was done, we started using it right away. And our surgeons had heard about it and they were asking for it. So it was imperative that we start doing it. And the most popular study that we found that they were ordering was lumbar spine synthetic CT. And it was mainly for all the patients that were having back pain for whom they were worried about spondylolysis. And this became kind of their study of choice because obviously using bone MRI, you can much more clearly see the defects than you can using traditional MRI examinations where sometimes these were even missed. I won't go through this slide. This is really MRIguidance's slide, but we are using that cloud-based application where we perform, we run the sequence on the scanner. The sequence loads into the PACS system, and it also uploads into the cloud-based server that he mentioned to you where the reconstruction is done. at the same time that the imaging is being acquired. We usually tell our radiologists and technologists that it'll take about 60 to 90 minutes for the sequence to turn around and return into the PACS folder. I haven't actually tested that to see how long it actually takes, but that's generally our timeline for expectation. And we evaluate the images at the same time that we read the MRI. So it's really in real time. And we use a DICOM hub through TeamPlay because we are a Siemens site. And so we're using TeamPlay to help send the images through the cloud. And again, this is, I won't go too much into the imaging of back pain because I know that that's going to happen next. But you can see, even though we're a center that uses 3D gradient echo sequence, like a VIBE black bone sequence, we routinely use the sequence to look for pars defects. But even our radiologists feel that the synthetic CT shows them much more clearly. And more than that, that it's not just the radiologists that feel like they're better visualized, but our referring providers can see them better, and even their patients, and they love to show their patients, and the patients just intuitively understand the synthetic CT images better. And not only that, but we can reconstruct them into 3D models as needed. And sometimes this is much even more helpful for demonstrating the findings. So our operational experiences, I'll go through a few of the things that we've done to make this work. We've been using this for maybe 6 months now or longer. And we found a few operational pitfalls along the way that we needed to fix in order to make this automatic. So the first thing is that you need to somehow know that your ordering provider actually wants you to perform a synthetic CT. That was the first problem. And the radiologist then needs to know how to protocol it, and the technologist needs to know where to find it. All of these things we had to do relatively quickly because our surgeons were asking for this as soon as it was available. And I'm just going to give you a snapshot of just the first series of orders that came through once this became FDA approved, just to show you what we were faced with as a radiology department. And we really needed to refine this ordering process. So the first thing we noticed is that people were just asking for this in the order comments, right? So it doesn't change the way you order a study. You're still ordering a lumbar spine or a pelvis, but they had to ask for it in the comments, and they would do it in any number of ways. But we might not see it, and it might get completely missed as you're going through a protocol list. And so sometimes they would be forgotten. Sometimes they were asking for bone MRI in an area of the body that isn't available yet. So some of our upper extremity surgeons wanted to see shoulders and elbows and complex deformities, but we had to let them know that we couldn't do that. As you notice, nobody's asking for a 3D model, even though they oftentimes want a model. Here's one where they're asking for a 3D model, but they're not ordering a 3D model. So that's another problem, is we don't know when they want the model, but they're not ordering the model, so we can't actually bill for the model. Sometimes they're actually ordering a CT scan, which actually is an intuitively logical thing to do. Sometimes they're ordering a pelvis, but they're ordering the wrong sort of pelvis. And then very much in the very beginning, they would send the studies to me to deal with. And that's an unscalable situation for me. So we had to figure out how to make this all automated. So the solutions that we put into place to make this an automatic workflow is we created new ordables. We use Epic as our electronic medical record. So we created new Epic ordables so that the orthopedic surgeons and the sports medicine providers and neurosurgeons, they have a new drop-down set of ordables, and I'll show you what those look like. We also developed new protocols for the radiologists so that they could just select, pelvis bone MRI or spine bone MRI, and it would just automatically populate the right sequences. And then we also updated the scanner protocol so the technologist didn't have to look for the sequence. We did one other thing, was we also updated our reporting templates so the radiologists could dictate the correct technique so that we would actually be able to bill appropriately. And a little bit about the billing. Just because we run a bone MRI sequence and create a synthetic CT does not allow us to change the CPT code of the MRI exam. So a CT of the MRI of the lumbar spine has the same CPT code regardless of whether we run a bone MRI or not. The only time we can actually add another code, and this is the code that we use, is when we perform a 3D model from the bone MRI sequence. And so it's really important for us to know if they want us to do a model or not, because that actually is associated with another charge. In our hospital, we have a 3D lab. So our 3D lab is staffed by technologists, and they are the ones that are doing the 3D models. And the models are completely dependent on the anatomy and the request. And so our technologists actually perform different types of models depending on what is requested. And again, this is a pretty early process, so I don't have many examples, but these are some examples of models that might be created. It's just standard, standard 3D models of the spine or the area of concern, whether the patient has spondylolysis, which is usually not a generator of a model because most of the time they don't need the model. But sometimes they want to look at the sacroiliac joints if there's pain. The surgeons may want to look at the morphology of the hips if they have some sort of morphologic hip disorder. Our spine surgeons really like the 3D models for the pre-op scoliosis. Sometimes these can be really tricky to make, but they love the models. And here's an interesting one in a patient with a bone lesion that I'll show you later on. We've also made a few refinements in conjunction with MRIguidance, in that initially we found that the images that we got were only available in the scan plane. So the sagittal plane for the lumbar spine and the axial plane for the pelvis. But this didn't really model a typical workflow for CT. When you do a CT, you typically get all imaging planes. And so we were trying to find a way to get the imaging planes in all three planes without exhausting our 3D lab. And now actually the images are coming directly from the server from MRIguidance reformatted into three planes for the spine. And the other thing we had to tell our technologist is not to change any of the parameters of the sequence and not to change the name of the sequence, because these changes would sometimes result in the image not reconstructing. So it was very important that we maintain the integrity of the sequence and basically lock it in the scanner so nothing can be changed. This is just a snapshot of the new orderbles that we created. Sorry if it's a little bit blurry, but we created these new orders. So in addition to having a straightforward lumbar spine, our orthopedic surgeons and our spine surgeons now and our sports medicine providers can see additional orders. So they can order a lumbar spine with BoneMRI and without a model, and they can order the spine with BoneMRI and a model. And that's true for the whole spine, the pelvis, and the hips. And the key here is that these codes with the 3D model are bundled with another CPT code so that we can actually bill for the creation of the model. All right, so I'm going to show a few clinical case examples. I won't go into too much detail on the spine because I know that that's going to come next, but I'll show you a couple examples of patients that we've scanned. Here's a patient, cervical spine MRI, and this patient had obviously edema, and they had some sort of an avulsion fracture at the posterior aspect of C7, and there was a little bit of an avulsion at this apophyseal ossification center, and that was just nicely shown with with the synthetic CT. We do a lot of patients with pars defects. And this is a patient who was 14-year-old male. He had 1 year of back pain. And on the conventional MRI, you can see that there's marrow edema in the pars on both sides and that he has a pars fracture and a pars defect. This was the original MRI that we did before we had BoneMRI. And the follow-up MRI was with BoneMRI. And you can just see that you can actually see the healing of the pars defect on one side and actually the healing of the pars defect on the other side. I think that everybody has just become much more interested in looking at pars fractures and pars defects with BoneMRI compared to the conventional way that we're used to looking at it, which is on these thin section gradient images. And now our referring providers prefer this as well. Some total spine imaging. This is a lot of our scoliosis surgeons are really, really interested in this. So here's a typical patient with a scoliosis who underwent posterior fusion, but before they underwent the surgery, we did a whole spine BoneMRI and had it reconstructed into all three planes, as well as a 3D reconstruction. And you can easily see the segmentation anomaly. And I can show you a video too, just to show you kind of what the model looks like. And then with these models, again, are created by our 3D lab. And of course, all the models can be generated however you like, right? Because you can generate your own models. A different patient, neuromuscular disorder and scoliosis. So this patient had a pretty severe scoliosis. Obviously, this is difficult to reconstruct in 3D, but then we got some nice models for the surgeon in this case as well. This is an older patient with a scoliotic deformity and a Chiari-2 deformity. This patient actually has had a prior spine surgery. I think he had laminectomies in the cervical spine. And usually that can cause some artifact, but in this patient, it certainly didn't distort any of the synthetic CT images. And here is the 3D bone model of his entire spine. Again, the surgeons are really impressed with this quality. And then this patient actually had both a conventional CT and a synthetic CT, so you can kind of compare side by side to see the quality of the conventional CT model versus the BoneMRI model. And then again, this is another example of a BoneMRI 3D model, or a 3D model created from BoneMRI images. And I don't think that we can tell the difference sometimes, and certainly our surgeons can. And the last thing I'll show you is a few examples of imaging of the hips and pelvis. So here's a patient who has Bartolotti syndrome, and so she actually came in with images from an outside institution, including a CT, that showed that kind of incomplete fibrous synchondrosis between S1 and S2. She had actually been worked up with a bone scan to look for uptake. This was where her pain was located. You know, these are just images just to show and tell. They asked us to do another repeat synthetic CT when she came to our hospital, and so this was our BoneMRI reconstruction. And I would argue it looks just as good as the original CT that she came in with. Again, no radiation required, and we can do it at the same time as the MRI. This patient, we actually reconstructed her pelvis just to show it better. And on the left hip, she actually had a total hip replacement. So in patients with a total hip, the hip just won't be visible. This is the iliac crest bone lesion I alluded to earlier. This patient had a lumbar spine MRI where they incidentally saw a cystic lesion in the bone, but they didn't characterize it. So they asked for a pelvic CT or a pelvic MRI with bone MRI. So we did the MRI and we added BoneMRI, and you can actually see that there is a lesion within the iliac bone. You can actually measure Hounsfield units of the lesion just like you would with conventional CT. And we did some 3D reconstructions just to demonstrate the degree of bony expansion. A couple other cases just to show how we used it. This is a patient who was undergoing posterior fusion for scoliosis, but the surgeons actually asked to see the pelvis in a number of these patients because they need to see the pelvis because the implants are going to extend into the pelvis. So we add the synthetic CT imaging to their spine and pelvic MRI, and just gives them some sort of a roadmap for their surgery. Again, I told you that we're a center for hip diseases, so we have a lot of patients coming in with morphologic hip disease, and sometimes they ask us to do synthetic CT just to better define the bony morphology of the hips. And then more recently, we had a request for a synthetic CT in an 11-year-old with concern for slipped capital femoral epiphysis. Clinically, I don't know that it added much value, but they really wanted to see the synthetic CT of this kid's hips. He had normal plain films. Sometimes we do MRI of these patients to make sure they don't have a pre-slip. And we also did synthetic CT in this kid. And you can just see how well it can reconstruct the pelvis, even in a kid with really wide open girth plates. So before I end, I'll just say that our surgeons, this is an email from one of our surgeons, and he used these words, thrilled, enthralled, and grateful, and they're really excited. Ed is my colleague. He's a neuro radiologist, and he and I work together on this, and they have been really positive with feedback for us. So we're continuing to work with our surgeons in collaboration with MRIguidance to make sure that we can offer them everything that they want. One of their requests is to combine the spine and the pelvis so that they don't have to do 2 separate exams. And, you know, that's something that we've been talking about. But here is just one interesting last case, and this just happened this week. The surgeon requested an MRI of the spine, but forgot to ask for BoneMRI, or didn't know that he wanted BoneMRI at the time of the request. So the patient came, had their study, and it was only the next day that he remembered to ask us to do BoneMRI. And so his question was, we failed to ask for synthetic CT, can it be done? And the default answer is no, it can't be done after the fact, although our neuroradiologist, Ed Yang, who's in charge of neuro protocols, was very clever, I think, and he changed the neuro protocol to include the Vibe-Dixon sequence, which is the sequence that is used to create bone MRI or to create the synthetic CT. So when they don't ask for a synthetic CT, we don't do it. But in this case, because we performed the source sequence that is used to make the reconstruction, we could actually just send it after the fact, and the reconstructions were performed the next day. We performed a 3D reconstruction, and he was thrilled because he said that this really helped him show the patient exactly what the deformity looked like. And so this was really, they were really excited about this. Just one word on the limitations that we've encountered when we've used it. Very mild limitations. If the patient has a substantial amount of bowel gas and anywhere close to the bone, you might have a little bit of artifact that obscures the bone. So this sacrum is a little bit, it looks like it's being eroded, but that's just bowel gas from the sigmoid colon. Here's another patient with a little bit of bowel gas from the sigmoid colon that's eroding the sacrum. And then every so often we see some punctate signal in the vessel. So here's one in an iliac vessel. This somehow, there was a little bit of signal here in the acetabular fossa, some in the aorta. Every so often we find a little vascular signal or tendon signal, and it doesn't impact our ability to read the image. And then if the patient has had surgery before, it's possible that there'll be susceptibility artifact that will distort the images. So this patient had multiple surgeries, and so this was the most artifact that we have ever seen. Other than that, the history of prior surgery hasn't been much of a problem. And I think that's all the time I have. And the point I wanted to make is that bone MRI for us has been hugely popular for our surgeons and our sports providers primarily. We're getting more referrals because they prefer this over what the competition has, which is generally UTE imaging. And we're hoping to expand to other body parts whenever that becomes possible. So now I'm going to stop and turn it over to Ken. And thanks for letting me share our experience.
All right, let me get my screen all shared here. All right, let's see. Continue to share. Can everybody see that there? Yes, perfect.
Yes.
Awesome. Well, anyways, Sarah, thanks. That was a fantastic talk. Stole a little bit of my thunder and some of the spondy stuff, but that's okay. We're going to go into depth on it a little bit. And as Sarah was mentioning, you know, it takes a real army from the radiologist standpoint and really to implement this stuff to its full capacity. And we are thankful here at Cedars to have one of her former fellows, Dr. Watterson, who's really taken the charge. And we found out very quickly that one person is not a scalable thing. When we start putting in the comments, attention, Dr. Watterson, on every single bone MRI we had. So we're currently in that early phase that you are in, but the bone MRI has been fantastic. And we'll talk a little bit about our experience here at Cedars Sinai in terms of dealing with our pediatric spine patients. So, 95% of my elective practice is pediatric spine. So I'm a pediatric spine surgeon, and then I do trauma as well. So let's talk about a little bit about what we do here in terms of the bone MRI. I have no relevant disclosures to this particular talk, but in our experience so far, hold on a second here, our experience so far here at Cedars, we're a little probably earlier phase than Boston Children's in terms of where we are, but we're ramping up. We've done approximately somewhere in the neighborhood of 80 to 85 of our pediatric patients between the two of us, Dr. Skaggs and myself, who do full-time kind of pediatric spine care. As Sarah was saying, the overwhelming majority of these patients have been patients who are undergoing spondylolysis evaluation and or treatment. But the other reasons that we found to be extremely helpful for these synthetic CTs and bone MRI sequences are patients with back pain, patients with congenital scoliosis, or patients who have scoliosis with back pain, where we're looking for potentially other causes that may be contributing to their pain outside of their deformity or outside of their curvature. Hold on one second here. There we go. This was a talk that I actually gave at the International Congress of Early Onset Scoliosis. And basically what we did was we looked at our first 25 patients who had this technology. And as you guys know, the majority of our workhorse for evaluating our pediatric patients is X-ray, plain radiography. But some of these deformities can be extremely complex. And understanding three-dimensional anatomy, both from a bone perspective, but also as a soft tissue perspective, is oftentimes extremely beneficial. So some of the indications in my practice for advanced imaging are atypical scoliosis, patients who have potential neurological compromise or potentially neurological compression, evaluation of back pain we've talked about, such as spondylolysis, degenerative disc disease, or patients who come in and may have some radicular pain concerning for herniated disc or again, some type of foraminal stenosis. And the other ones, again, is congenital scoliosis. We get MRIs pretty much on all of our congenital scoliosis kids, especially the ones who we're planning on taking to the operating room. We've talked about the pros and cons to CT and MRI, and we're not going to belabor that, but we know that MRIs have pros to them. You can evaluate the soft tissue. They don't have ionizing radiation. And then CT scans are way better at looking at bony detail. Sarah mentioned how many times the surgeons say, no, I want to see the bone. I want to see the bone. And as bone doctors, we want to see the bone. So CT is super helpful for that. But when we're talking about our pediatric population, we want to try to limit the amount of radiation that they're seeing, and CTs carry a lot of ionizing radiation. So following this concept of as low as reasonable achievable for our imaging protocols for our kids who are growing and who are, increased susceptibility to the impacts of long-term radiation exposure is critical. And so the best of both worlds really is kind of the holy grail from an evaluation standpoint. So we looked at our first series. So we started using BoneMRI in October of 2023. All right, and we looked at our first kind of series over about an 11-month period. And we included all of our patients who had synthetic CTs, and our patients were consecutively evaluated. And then some of those patients also had traditional CTs. So we were able to leverage those in order to compare the two, which was a nice comparison. Of those who had traditional CTs, as well as they had synthetic CTs, we did 9 anatomical measurements in order to compare the two scans to see kind of how those correlated. So we had 25 patients who underwent a synthetic CT of the spine. 2 of those were cervical, and the rest were majority lumbar spine, with a mix of some who also had some thoracic spine thrown in there. So 2 of these patients actually I scanned. They were my patients who I scanned for congenital muscular torticollis. These were older patients who had residual deformity, who I was planning on taking to the operating room for bipolar sternocleidomastoid release for a soft tissue deformity correction. But what you never want to do is do a soft tissue deformity correction and have some underlying osseous vertebral anomaly, which is actually the culprit of why they have a persistent head tilt. So oftentimes it makes me feel more comfortable inside to have some 3D imaging to know that I'm not missing some osseous anatomy, which is causing the tilt. And so you can see those scans here at the bottom where you have the MRI and the coronal synthetic CT, as well as the 2 3-dimensional CTs that we were able to reconstruct for these 2 patients before they went to the operating room, and they did not have any congenital anomalies, and they underwent bipolar sternocleidomastoid release. As we talked about, the overwhelming majority of the patients that we see who we get this technology on are patients who either have spondylolysis or spondylolisthesis. All right, in this particular series, it was 15 out of the 25 patients. And again, you can see down here at the bottom, your MRI scan, as well as your sagittal, as well as your axial synthetic CT demonstrating a spondylolysis with an ipsilateral pedicle fracture. And then the remaining patients were ones who had back pain, who we weren't quite sure what the pathology was potentially, whether they had underlying stress fracture that we just couldn't see on x-rays, which is very common, or whether they had symptomatic transitional anatomy, such as Bertolotti syndrome, or if they had back pain with scoliosis. Also, patients who had congenital scoliosis, we also have started to use this particular technology because understanding the 3-dimensional bony anatomy is unbelievably critical, especially if you're planning some type of surgical intervention from a surgical planning perspective. And this is one of those patients. This is a patient of mine who is a 17-year-old male who has morbidly obese, chronic back pain, and left-sided radicular pain. And we were able to get a bone MRI on him. You can see the coronal MRI on the left, as well as the CT scan, the coronal CT. And then you can also see the 3-dimensional CT. And we were able to take that particular scan, create the 3D model that you see on the right, which allows us to bring this into the patient room, really have an educated discussion about, okay, here's what's going on. You have significant degenerative disc disease. Your facets are all sclerotic in the back. You've got all kinds of congenital anomalies, as well as having multi-level foraminal stenosis on the left, you need a decompression, you potentially need an L3 to sacrum and or pelvis fusion because of his morbid obesity and his deformity that he has there. So 10 of our patients also had a traditional CT scan within 3 months of their synthetic CT. So we were able to leverage that and trying to look at whether they were similar in terms of measurements. Those were all subjectively reviewed by the pediatric spine surgeons as well as their fellowship trained MSK radiologists. 9 of 10 of those were quote unquote subjectively the same. There was one patient who I'll talk about where there was needed an addendum to the radiology port, but we'll go through that. So up top here, you can see this is an example of one of my patients. We actually just published this case report in JBJS. This is the first patient I ever used a bone MRI on in my practice. And he was absolutely eye-opening and game-changing for me. So the top scans are your traditional CT, and then your bottom scans are your synthetic CTs. And you can really kind of see how similar and how identical these are in terms of picking up these bony pathologies and really understanding the characteristics of the fracture pattern, which are extremely variable. Here's an example of the patient who required a radiology addendum. They actually had the CT scan, traditional CT scan, which is all the way on the right first, and then they had the they had the bone MRI first with the synthetic CT, and then actually got a traditional CT later. And what the radiologist says is they didn't really pick up that they had this anterior kind of inferior in-plate ossification with some adjacent edema. They didn't pick that up to begin with. And so they required a kind of a revision of the radiology port. But that's the only time that we've seen any difference whatsoever. And it was extremely mild and subtle. Just from a results perspective, about 62% of those measurements that we had for the traditional and synthetic CTs were within 5 millimeters of each other. So Peter said sub-millimeter accuracy. That's what we're finding here. 95.5% were within 1 millimeter. The largest difference that we found was 1.3 millimeter. Again, very close to being all sub-millimeter clinical accuracy for these, which is absolutely fantastic. So we concluded from this presentation, this paper, which we've just submitted for publication, is that MRI-generated CT is really a great radiation-free alternative for imaging modality in these patients. Potential for future from navigation-free robotics, spinal navigation. There's a whole lot of options there from a surgical perspective. And then in my practice, really game changer / game practice changer from an evaluation standpoint, from a scoliosis, from a congenital scoliosis perspective, as well as from a spondylolysis perspective. So we'll talk more about, our spondylolysis population. I think hopefully everybody on this call knows what it is, but if you don't, it's a unilateral bilateral defect in the pars intra-articularis. The most common reason these things occur is because it's repetitive trauma in a genetically susceptible individual. And I can tell you, we have little information on why these occurs, why they occur, who they occur on, why they occur in certain people, why some people are symptomatic, why people aren't symptomatic. And when you get experts in the room who talk about these spondylolysis things, it's all over the map. And that means we really don't have good data in terms of understanding how to evaluate and treat these patients as of now. But that's going to change, in my opinion, largely based off of this technology. So the incidence of spondylolysis in my practice has shot through the roof in the last 5 to 6 years. And it's amazing how many patients I see with a spondylolysis on a weekly basis nowadays. Again, genetic factors, activity factors. In my clinical practice, activity factor, I think, is huge. Every time I see a gymnast on my schedule, I almost always know they're going to have spondylolysis or some low back discomfort, because gymnastics is hard on the back, repetitive hyperextension of the lumbar spine with a lot of rotational stress, which leaves the lower part of the back prone to these stress fractures, these spondylolysis. But this is the big issue: pain. Spondylolysis in the general population is about 5%, but not everybody is symptomatic, right? And so spondylolysis, when it causes significant back pain, is where it becomes a problem. But we also don't have a good consensus on the best imaging modalities to look at these things in the past. And this was a review article from 2017 from Stu Weinstein, who's a giant in our field from a pediatric spine perspective. And their key point conclusions: there's few consistent recommendations for how to effectively utilize imaging in making the diagnosis of pediatric spondylolysis. And I would say that I would agree with that statement up until now. This is a very classic kind of patient in my practice. This is a 14-year-old male, 6'4" volleyball player, presented to a sports medicine specialist. He had a diagnosis from that provider as posterior iliac apophysitis, and he was treated conservatively with PT for that diagnosis and had 6 visits over 9 months with absolutely no relief of symptoms. He had a lumbar MRI that was ordered, which there's the lumbar stir sequence, as Sarah talked about. You can see that pathognomonic edema within the pars interarticularis and the pedicle. But what we found and what we've published in the past is that unfortunately these things still are occasionally missed. And here's the official radiology report from the outside facility, which says there's no acute osseous or soft tissue abnormalities, which allowed this patient to have a diagnosis of spondylitis, but not be diagnosed in a timely fashion to get appropriate care that he needed. We've published on this in the past at our institution. Dr. Skaggs has published on this, showing that spondylitis is potentially frequently missed at MRI in adolescents with back pain. We are also in the process of looking at our patients now here at our institution since 2021, and we showed about 20% of the time a radiology report will miss a diagnosis just solely based off an MRI. And most of the time, it's purely missing that pathognomonic edema sign that you can see in the pedicle and the pars. And the majority of those particular radiology providers were non-fellowship trained. The big one is that it potentially significantly delays the onset of care to a specialist. So if they had an MRI with an appropriate read, they were 6.4 months when they saw us onset of symptoms. However, if they had an inaccurate read or didn't have an accurate diagnosis based off the MRI, that ballooned up to 10.8 months. So these kids really are getting delayed in terms of a diagnosis perspective. Here's that same kid. He has this L5 edema within the pars and the pedicle, consistent with some type of spondylitis. He undergoes 12 weeks of rest. You can see the resolution of his edema there. And then unfortunately, after 6 months of a return to activity, he had onset of pain again, and you can see that edema there as well. Here's 3 different MRI scans, okay? All of these, I would say, look fairly similar to my orthopedic eye. Sarah might say look a little different, but you can see the edema within the pedicle. You can see the edema within the pars. All of these, in my mind, are on the what I call spectrum of spondylitis. This is a pathognomonic sign, in my opinion, for what I've coined as spondylitis spectrum disorder, because we use this spondylitis term for varying different degrees of fracture pathology, right? And these things come in all shapes and sizes. Here, the one on the left, you can see that there's a sclerotic hypertrophic reaction of the pars interarticularis. The one in the middle actually has a pedicle fracture with a healing pedicle fracture with a contralateral spondy/laminar fracture. And then the one on the right has a bilateral spondylolysis with extension into the transverse process. These are hugely different osseous anatomies, all for a same diagnosis from an MRI scan, okay? And again, I think we can all agree that the difference between the patient on the left with this chronic sclerotic spondylolysis is much different than the patient on the right. So understanding the osseous anatomy of these scans, I think, is highly critical for understanding how we treat these kids and how we better define who needs treatment, both from a conservative and from a surgical perspective, okay? Here's just another patient. Again, you can see the pathognomonic sign of edema within the L4 pedicle there. This is his synthetic generated CT. This is the first patient that I ever used this technology on. You can see that he has this L4 bilateral spondylolysis, beautiful pictures. This was an axial CT scan. And when you compare the MRI to the middle, which is the traditional CT, and then on the right, which is the synthetic CT, you can see that the accuracy in terms of these, clinically, when we're looking at these, they look identical. The synthetic CT looks identical to the traditional CT, and we're really able to pick up those cortical details in order to help make correct diagnosis and come up with a surgical plan. This patient underwent surgical fixation because he had chronic pain for greater than 1 year, so we ended up doing a robotic-assisted percutaneous intralaminar screw for fixation of his bilateral pars defects. Unfortunately, I did not use the BoneMRI for intraoperative navigation. I do think that's the way of the future. We have not done that here at Cedars, but we are in the process of performing that and kind of going through that workflow so that we can perform radiation-free robotic and navigation surgery. And then over here on the left, you can see where he started. These are his screws. These are intraoperative O-arm span. And then on the right, we in the past used to get CT scan follow-ups at 3 months to confirm healing on all of these. And what we found is that, almost all of these are healing. So I don't get a CT scan all the time because that's a lot of radiation for this particular patient. But you can see we got good healing at 12 weeks. He's gone back to sports. So my general imaging workflow from a spondy perspective is 2 views of the lumbosacral junction. Oftentimes you can't pick up the spondy unless they have a spondylolisthesis, or rather it's really obvious. If there's a high clinical concern, we get an MRI of the lumbar spine with BoneMRI, synthetic CT on everybody nowadays. It's my standard workflow. Everybody gets it. We get a repeat MRI of the lumbar spine with BoneMRI synthetic CT at 12 weeks to assess for resolution of edema and also to assess the osteoanatomy. Is there any signs of healing? Is there no signs of healing, right? It gives us a better idea of kind of who needs to be treated and kind of what the clinical outcomes down the road. Whereas traditional CT, no way I would ever repeat scan a kid 3 months later during conservative management. There's no chance. Adding that radiation doesn't make any sense. It's not worth it. But with this technology, we're better able to assess the osseous healing and what the osseous structures are doing over time for both the conservative and surgical management. This is a 10-year-old male gymnast. Actually, he's on my schedule for Monday for a bilateral, same procedure, bilateral robot-assisted percutaneous screw fixation, chronic pain. This is his traditional CT scan that he had. He came to me with this particular scan and did not have an MRI. No MRI, came just with a CT. This was the bone MRI that we ordered, which again, you can see the edema within the pars. And then when we compare his traditional CT again to his synthetic CT, it's near identical in terms of the osseous anatomy, in terms of picking up the small cortical details. And when I actually measured the interlaminar distance, for what size screw I need, I measured both of these and they were both within about 0.2 millimeters of each other in terms of determining what size screw I need to put across this in order to stabilize this fracture. Here's another interesting case. This was a 15-year-old female soccer player. She came to me with this MRI and CT scan over here. So again, you can see the MRI on one side is hot. You've got some pedicle edema over there on the left side. On the right side, actually no edema on the MRI. And you can see the corresponding traditional CT scan where she's got a chronic left spondylolysis with sclerotic borders. That thing's never going to heal, in my opinion, especially with conservative management. And then on the right side, she has a pedicle fracture. Again, I consider these all in the same spectrum of the same disorder, same type of pathology of how they occur, and they usually look pretty similar on MRIs if you don't have special sequences. But those pedicle fractures, I think we can almost always get those to heal. All right, so we get we shut her down, clinical rest, 3 months of rest, no sports, and we get a repeat MRI. Shows that there's resolution or resolving edema, significant resolving edema. And you can see on the synthetic CT from the BoneMRI that bridging callus across the pedicle. And you can start to see that guy starting to heal. And that correlates with the symptoms that she was having in terms of pain was resolving. We ended up resting her for another 6 weeks. She's gone back to sports, has not had any pain since. So I think BoneMRI really is a game changer for me for spondylolysis because one, I think edema is important. I think it's good to understand what the edema means. It means there's an acute active process, and usually it correlates with pain in my practice, and I want to know what's going on. I think it's unbelievably important to understand what the disc evaluation is. Both of these patients have spondylolysis to a very different degree. Both are of similar age. One has beautiful disc, one has terrible disc with a spondylolisthesis. Okay, so understanding disc anatomy, I think, is important. I also think it's important for monitoring of edema resolution. I think that correlates with symptoms, and I think it's important for us to follow and to completely understand what that edema entails, because I think it's important from both a conservative and a surgical treatment perspective. What we found is that if we operate and we do a primary repair of an interlaminar screw on a spondylolysis, and the MRI has no edema, there's a higher chance that you're going to get a non-union at that site. Okay. Again, understanding osseous anatomy of spondylolysis spectrum disorder is really critical, both from a conservative management as well as from a surgical management into figuring out how do we best treat these kids? Which ones are going to be prone to failing conservative management? Which ones can we get to heal? Which ones need a bone stimulator? Which ones don't need a bone stimulator? Which ones may end up with surgery down the road? All of these things, these synthetic CTs are going to be absolutely critical for us to finding out this information. This is my algorithm for how I currently manage all my pediatric and adolescent spondylolysis patients, and littered throughout this algorithm in terms of how I assess all of them and how I treat everybody. Every step along the way in these yellow boxes, all is where BoneMRI plays a critical role for me now in terms of both evaluation and also evaluating on which patients are going to be optimal from a treatment perspective. And that's all I got. So thank you everybody for your time. I really appreciate it.
Thank you, Dr. Illingworth, Dr. Bixby, and Peter for the great presentations. We have some questions already in the chat, and you can continue dropping the questions you may have. I see a lot of interest of how young the patients have been scanned. So Dr. Illingworth, Dr. Bixby, what is the ages that you have scanned the youngest patients?
Well, what's the FDA? What is it approved for? Let's start there, Peter. What's the approval for what the age is?
Well, the approval is 12 years and up. And this is because of reasons that we need the evidence for also individuals lower than that age. And we are working on that. And obviously we have seen people using it under that age. But I think the question now is to both of you. What is your experience with patients under 12 years of age?
Well, I just showed a 10-year-old, and so hopefully I didn't do anything bad. But all over the radiology report, it says off-label, off-label. So I have no issues ordering one off-label in a 8, 9, 10, 11, 12-year-old. I have not ventured into the really, really, really young kids. If you're talking about, infantile or early onset scoliosis kids less than the age of 2, we have not really proceeded down that route yet, but I certainly think there's tremendous amount of value for that going forward. And if we're able to show that it holds value and that it's reliable, it's going to make a huge difference. Because again, some of our early scoliosis patients need MRIs early on in age, and having synthetic CT could be of significant value.
Yeah, I agree with you. And in terms of off-label, many things are considered off-label in kids that we use routinely, including gadolinium. So, we have run BoneMRI in kids younger than 12, but not as young, not very, like 8, I think was the youngest that we've run. And that's just based on who's referred to us. We don't typically have babies referred for this.
Thank you.
Great, thank you. There's another question regarding how BoneMRI can handle metal artifacts.
Yes, I can also elaborate on that. Well, the BoneMRI technology is based on a 3D gradient echo sequence, and that sequence is just like any other MRI sequence sensitive for osteosynthetic material, for metal. It means that wherever there's osteosynthetic material, there will be a signal void, and the BoneMRI algorithm is not solving that signal void. It means that we do present that metal with a hyper intense signal, but very close to the metal, let's say millimeters, we just state that you shouldn't trust the BoneMRI, so you shouldn't measure or try to assess loosening of screws or do measurements on the metal very close to that metal. That's something that we want to stress.
Thank you, Peter. And we have another one in the chat. It says that I find T1 Vibe is really good at detecting spondylolysis. Practically, how much better is synthetic CT at detecting such lesions?
Yeah, so in our hospital, we've been running T1 Vibes routinely for this, and our radiologist felt very strongly that is sufficient for detecting PARS lesions, PARS defects, spondylolysis, and they didn't really believe that the bone MRI would be necessary. But when we started running it, they actually became converted because they could see them much more clearly. So I don't know. I think that yes, the T15 is really good at looking for spondylolysis. I think the synthetic CT is a little better from a radiologist perspective, but it's definitely better from a referring clinician, referring provider, patient communication perspective.
I think if everybody used it for every potential spondy kid, it would drastically decrease the chances of missing that diagnosis and lead to earlier treatment and earlier subspecialist referral.
Dr. Bixby, can we ask a question?
Absolutely, go ahead.
Our radiologists have been very, very reluctant and dragging their feet to adopt this. Do you think it's just the cost or liability or extra work and learning required or longer scans or what? Have you encountered anything like that?
So there's definitely there's an activation energy to implement this. There's a lot of work involved from everybody, legal, IT, technologists, radiologists, pretty much everybody in the department gets involved in this in some way or another. So they have to be committed to do it. The cost, yes, it has to be budgeted, right? So somehow your department or your hospital has to have the budget to be able to pay the service. So I don't know if it's a budgeting issue. The cost isn't significant, but it's a budget item that has to be approved. And then it does add time to an MRI scan. The sequence takes about 4 to 5 minutes, but that time is often compensated if you can perform a 3D reconstruction that then you are charging for. So, in some ways, we feel like there is a bit of a cost to doing a bone MRI because you're not getting paid directly by the insurance company for doing bone MRI. It's like a free sequence, but it's such a bonus for the exam. You get so much increased referrals. It may just be all of the lift to get it going. But otherwise, I don't know why they would be resistant to try it, but.
I don't know. Thank you very much for a great presentation.
Oh, you're welcome. It is also a little bit of a cannibalization of CT volume. So there's that. Yeah, that's what Mahesh just said. It does take CT. You're going to be doing less CT if you're doing bone MRI. Yeah.
Is the
Great.
pay model a pay per exam or is it a subscription fee?
I'll let.
I'm sorry, can you repeat that question?
For purchasing bone MRI, is it a pay per exam or is it a subscription fee or both?
Oh, well, we started off with subscriptions, but we now tend to offer pay per scan because that also better relates to the reimbursement strategy that we are now following. We have applied for a new technology APC, and we get advice from societies, and based on that knowledge we gained in the last 6 months, we really are trying to make it more like a pay per scan module.
Thanks.
Thank you, Peter. There's another question right now in the chat. Could you mention a bit on work on other regions like cranium or extremities?
Yes, I can, of course, talk about that. We are in the process of course, expanding to different anatomical areas. Extremities are very interesting, but we are now currently first focusing on adding the cranium to really complete the spinal cranial axis. But we also have models for shoulder and for knee, research models. We have been publishing on them. it's all on the horizon, but it's more like a resource thing in our still relatively small company that we have make choices. And the first next anatomy will be the cranium. And there we're also aiming for younger children under 12 years of age.
This is a quick question for Sarah. It's Mahesh Thapa. We have adopted the Murphy protocol for a lot of our hip dysplasia, acetabular dysplasias here at Children's that you guys use at Boston. And we frequently scan down to the femoral condyle so we can get version information. Has that been used, or is there a plan to use something like that with bone CT? It's bone MRI.
Yeah, for that reason, we still do the CTs on those patients because like you said, we do the CTs of the femurs, complete femurs. And so bone MRI still doesn't go to the condyle. So we're not using bone MRI for version analysis. But
you could just scan down to, right?
I don't know. I guess that's a question for Peter. I don't know that you can.
So from what area do you want to what do you want to include? Also from the knee or just
from hips down to the knees?
Yeah, well, the difficulty is it is not FDA approved yet to scan the knee and to take the knee also in the reconstruction. We do know that the models work, but that's just what it is. At this moment, I think we cannot offer that yet.
Not even as off-label.
So the thing is the scan time, right? Because scan the whole femur would probably be what, much longer.
As a vibe, yeah. You could do it as vibe Dixon, right? Is that the required
The sequence in the pelvis is not a vibe. It's just what is a flash? I can't remember. But
yeah, it's a RF spoiled 3D T1 weighted gradient echo, and I think that's closer to a flash, 3D flash.
Yeah,
because right now we still do we do MRI for the labrum and we do CT for the Murphy protocol. It'd be nice to do both as an MR.
No, I totally agree. Scan time would be a bit of a challenge with that to do the whole femur though.
And I think the good thing is that the vendors, the MR vendors, of course, provide functionality to reduce scan time with deep resolve, with compress related things. And we have recently also shown and approved that we can use those type of scans for reconstruction. That could bring a 4-minute scan down to 2 minutes, but that's then related to the to the innovations of the MR vendors, and that should also be available for you in your institute then. And maybe for the radiologist here in the meeting, it's also good to know that we are now far underway to also reconstruct a T1, improved T1 contrast, more resembling a T1 TSE from the gradient echo. And that means that you can leave out your T1 TSE out of the protocol. That's often part of a musculoskeletal protocol. So that balances out the additional scan time for the bone MRI because you can leave out the T1 TSE. And then you get a bone MRI and a T1 TSE from the bone MRI source data. This is approved in Europe, and we expect this to be approved end of the year in the US.
You mentioned something about next frontier being the cranium. Are you thinking of things like perhaps including temporomandibular joints or temporal bone with these? Do you think this would be good for middle ear pathology and things like that, or do you think there's too much air interface with the ear cells?
Yeah, the focus will be on neuronavigation. And I think on the neurocranium, maybe the mandibular bones will be well reconstructed. We see that already in our models. But what you mentioned, everywhere where air and bone is very closely adjacent, it still will be challenging. And for example, for the inner ear, that if you really want high detail of air pockets in the bone there, well, then probably bone MRI will not be the best choice. But there will be many applications also in children, craniosynostosis, related things, deformities, where bone MRI can play a role.
Great, thank you.
Thank you, Peter. Just for the audience, there is a small survey that we value your opinion, so you could fill it in. And we're already over time. So, Peter, let's close with one last question. What exactly does the AI add? What's the secret sauce?
Okay. So normally we tend not to advocate our product as being an AI product. We feel like AI is actually helping us to generate the algorithm, and that's done based on thousands of paired data sets, MRI and CT data sets. And based on those data sets, our algorithm has learned the relationship between MRI signals and CT signals. Once that model is learned, and that's done using AI, using neural networks, we have an algorithm, and that algorithm is frozen in the sense that it's just the method that converts the MR into CT data. So it's not a continuous learning thing. It's not taking your data when we are providing our models to you. It's just that the algorithm uses AI to improve finding the relationship between MRI and CT.
Thank you, Peter. And I think with that, it's good time to close our today's webinar. Thank you, everyone, for joining us today. I wish you a very good night. And for the question that we didn't answer, we'll follow up with an email along with the recording. Thank you very much.